but I've been doing medical liability over the past 5 years, so investigating cases, and now taking it from the legal aspect, not only the medical aspect. Along that, there is, I've done Master in Quality and Safety in Healthcare, where comes relevant. So the main lesson I learned in Master in Quality and Healthcare Management is Deming, who's the founder of quality in medicine, says, it is contended that up to 85% of the variability in work performance. So if you don't perform well, 85% of the time, it's a system error and not an individual error. So I've always wanted physician and healthcare worker to keep that in mind. When we deviate from standard of care, it's usually the system is not safe. If the system is safe, as a human, I will make error, but that error should not reach the patient. Now, here is the main lesson I want you to remember from all the legal concepts we're going to discuss, that بالعربي الأصل براءة الذمة. So, the Universal Declaration of Human Rights says, everyone charged with penal offense has the right to be presumed innocent until proven otherwise. So, if you ever had been under investigation or in the future, always remember you are innocent until it's proven at the last minute that you are guilty. Most of us, when we become under investigation, we start blaming ourselves and we think we are guilty when in fact we might not be guilty. So this is an important concept to remember. Now, what we will discuss in the next few minutes would be history and origin of medical liability law, important terms and definitions, common malpractice claim in various specialty, given that this conference, there are many healthcare, the audience is from different specialties. And then I would go over the procedure of claims in UAE. What's the procedure to investigate medical liability claims? Now, show of hand, how many of the audience does practice in UAE? Okay, few. So most of the concepts are international, so apply in any jurisdiction. However, there are specific sort of concept, which is the procedure and all that is more specific to UAE. So it dates back to Hammurabi Code. Hammurabi Code is the first written law known to humanity. So Hammurabi Code was about 288 articles. One of them did say, doctor should be punished if the doctor makes a mistake causing harm to the patient during surgery. Now I'll give you a little bit of feedback. When medicine was not known in the Middle Age, right? So when medicine started to come, people were mixing between medicine and magic work, اللي هو السحر والأشياء هذه. And from there, they were a bit harsh on people who practice medicine. So that's why when a patient suffer a harm, they would always blame that doctor because they did not recognize medicine as a profession. Now, unfortunately, it did stem to our days where sometimes people, even when patients sort of like kind of suffer a complication with a result to medical error or just complication of the disease, we always jump to blaming the doctor rather than thinking if this was a deviation from standard or not. 5th century Hippocratic Oath was there, and the rule is first do no harm. So it's all about causing harm to the patient more than anything else. And then the first recorded medical malpractice case was in 1374. So it dates back many hundred years ago. And then only in the 19th century where medical liability codes start to come, and then we start to see a little bit more regulation for sort of like cases or claims that comes against healthcare professional. Now, in United Arab Emirates, the first law that defined medical error was 1975. The law still exists until today. However, that law is simply the law to regulate practicing medicine in UAE. So back then, it was only one law and did include medical error definition. That law kept updated 1984, 1996. Until 2008, we had the first medical liability law published. And then it was updated 2016, which is still running until today. Now, let's look at 2016 law, so the law that applies to us today if we commit any, or if there's any claim against any of us in this room. So, simple, Article 4 tells you, as a physician, what should you do? Now, show of hand, who did read the medical liability law in the jurisdiction where they practice? Hands up if you did read the medical liability law where you practice. Wow, that's almost 0%. Okay. Now, in the literature, and in every single conference I did teach, there is always a few hands. The literature says that's about 10 to 20% of people only read the law among healthcare professionals, which is a bit surprising because you cannot drive a car without going through all these regulations of the traffic law and without knowing what's right, what's wrong, what you should do, what you should not do. Yet we do graduate from medicine, we do go through postgraduate training, and we do practice medicine, but yet we never read the law. So this is a message for you today. When you go home, do Google the law where you practice, and you have to read it. I mean, you just can't practice without understanding your rights and your responsibilities. So what physician is obligated to do? Simply that long page there, you can summarize it here. We should do history and physical exam. We learned that in medical school, it's not a big deal. You should come up with diagnosis, and here I would say differential diagnosis. We are not obligated to find a diagnosis because sometimes it's very hard to be found, right? But at least you go in the right path trying to find that diagnosis. You should offer the patient treatment options and not only dictate you must do this. And then you should collaborate with other healthcare workers in the care for that patient. And you should explain to the patient their illness, their disease, and their treatment plan. Now, what you must not do. You should not treat any patient without a consent, and that's the biggest kind of, in every single specialty, many of the claims, the physician is convicted either for lack of consent or the consent is lacking important details. So just signing the consent without explaining the procedure in the consent and without writing possible complication, common complication, then that deemed the consent may not be adequate. Refusing to treat a patient, that would be illegal. And then use unauthorized treatment. So if you would use a treatment, make sure you have a backup. Either this is standard of care, there is a new literature coming about new treatment, and then how you should apply that treatment. So if you would apply a new treatment, I would say you have to have a literature to back you up. Prescribe medicine without examining the patient. So if a family member comes to your clinic asking you to prescribe medicine to their sort of loved one at home, be careful. Now, if you are an internist who follow up that patient, elderly at home or special need, who can't come every month for refill, that's acceptable. So medication by proxy. But other than that, likely prescribing medication for a patient you have never seen in the past or he's not following up with you, that would be considered illegal as well. And then disclosing patient information. In the medical liability law, in UAE and in any other jurisdiction, there'll be specific situation where we as healthcare professionals can disclose information. Other than that, the rule is any information that we receive from the patient is confidential, except in these situations where we are actually obligated to disclose. So now, terms and definition. And this is important. Now, did any of you, was any of you involved in medical investigation of another colleague? Like your opinion was sought as an expert in the field to tell them, perfect, so there's a hand up there. So to tell them if there's a medical error or not. Now, many of us, they can seek our opinion as an expert in the field. Now, I'll tell you, being an investigator for the past 5 years, many of us would take it from the clinical quality perspective, not the legal perspective. And both perspectives are different. And if we don't realize that difference, we will be convicting our colleagues as committing error, when in fact they did not commit a legal error. So I want you to focus with me in these terms and definition. So medical error, there is a clinical definition that we use in every day in our life at the hospital, and there's a legal definition that many of us don't know. So the clinical definition is deviation from standards of care. The simplest example, paracetamol dose is 1 gram. If I give you 2 grams, That's deviation from standard of care, right? That's a wrong dose. So that's a medical error if I'm doing an investigation as quality. But when it comes to legal definition of medical error, it starts with the harm.
3 minutes, please.
Oh, wow, okay. We're just starting, warming up. Tamam. So simply we start with the harm. So if what I did is wrong clinically, but did not cause harm to the patient, that's not a medical error legally. So keep that in mind. Now, medical liability, so this where we say it starts about the harm, it starts with the harm. You are legal for the damage you cause for the patient. So I did cause a damage, I did deviate from standard of care, and there is a direct causation relationship. My deviation did cause the damage. Here, I'm legally responsible. Other than that, it's a clinical error, but not legal medical error. So that's exactly what we just discussed. Now, in UAE, there is medical error definition in 2016 law, and in 2019, I lost the term now. But there was another executive document that came to complement the 2016 law. It does define gross medical error. Now the difference, medical error is a civil liability. You will pay compensation for the patient. Gross medical error, if the gross medical error led to death, there might be imprisonment, so session, 2 years, plus minus the monetary compensation. So that's important to keep in mind, the difference between the gross medical error and the medical error. Now, I'll skip this slide. So gross medical error, if it leads to death, loss of organ or function of organ, or any other gross damage to the patient. And then it gives you about 7 to 9 criteria that did cause this gross medical error, and then you can call it gross medical error. So that's as well important when your opinion is being sought as expert in the field. Medical malpractice, it would be, you need to meet these 4 element criteria. Now that's not defined in UAE medical liability law, but that's international definition, which is between the lines. You can read it in UAE medical liability law, but more legal people will understand it rather than us physician. So you need to have professional duty to the patient. So if I'm at home, I'm not on call, they cannot come and hold me accountable. So I have to have duty to the patient. I have to breach that duty, and then that breach cause injury, and that injury cause harm.
Dr. Aisha, 1 minute left, please.
طيب.
Thank you.
So Sentinel event, that there is a Ministry of Health definition, so look it up, you'll find it. I'll skip the types legal, so let's go to common malpractice pitfalls. Internal medicine, they usually misdiagnoses. I mean, that's their job, more or less diagnostic, right? Procedure error, failure to properly monitor resident or nurse. So if you're in teaching hospital, you are the MRB, you are responsible. So it's your job to monitor the people working with you in the team, rather than if they make a mistake, that they carry that mistake. Medication error common in medicine. Now surgery, most of their medical error happen intraoperative, and this is literature based. So most of it is lack of skill, more or less. I'll skip orthopedic, I'll skip urology. Pediatric, most of the error happen above 1 year old. I guess we are very careful when child is less than 1 year old. And misdiagnosis is common among them, meningitis and appendicitis. They tend to miss that kind of commonly. Then childbirth injury and medication error as well. So this is the last slide, the procedure in UAE if there is a medical claim. Now, first the patient has to submit a claim to the local authority where they were treated. So if he was treated in a hospital in Abu Dhabi, I have to submit to Department of Health. Every local authority has their own medical liability committee. They will have to investigate, they'll have to issue their report, which will take somewhere between 1 month to 6 months to 1 year even. Once they issue the report, you have 30 days as physician or patient to appeal. If you appeal, you don't accept the result. And I would say, if they tell you you had made a mistake, always appeal. Even if you think you had made a mistake, always appeal. Tamam? And then if they appeal, if one of the parties appeal, it would go up to Ministry of Health, Higher Committee Medical Liability, who would reinvestigate from the beginning. And again, many times the local committee would say there is medical error. It would go up to higher committee. They would say there is no medical error. So always appeal. Just take that as a rule.
Dr. Aisha, thank you very much. We can come to a conclusion.
Perfect. So if medical committee says there is an appeal, patient can go to the court. If they say there is no medical error, he cannot go to the court. So to conclude, law literacy is a personal responsibility. You have to read the law. You cannot practice without reading it. We need all to follow standard of care. Documentation, lack of documentation haunts us as healthcare worker. And then the process in UAE, honestly, in my personal opinion, is in the best interest of both physician and patient. There is a room for improvement, which hopefully going to come in the future. Thank you so much.
I would like to introduce myself. I'm Dr. Basman, consultant anesthetist in First IVF in Abu Dhabi. I'm a moderator in this session, and I would like to invite Dr. Baha Sheikh. He is a consultant anesthetist, fellow of Royal College of Anesthesia, consultant in William Harvey Hospital, United Kingdom. His presentation is how to write a medical book. Wow.
Good afternoon. Really, today the talk is how to write a medical book. The purpose for this talk is hopefully to encourage other colleagues to publish rather than, I'm not going to talk about anesthetics or anything, is a general talk. I'm going to squeeze in 10 minutes 33 years of my experience in publishing and writing. I qualified from Baghdad in 77. I did my postgraduate training in Britain in the 80s. Worked as a consultant anesthetist in Kent in a hospital called William Harvey Hospital. Those of you who are not familiar with William Harvey is the guy who discovered the systemic circulation. 300 years before him, Ibn Nafis in Damascus, in Cairo, he described the pulmonary circulation. Very quickly about anesthesia in the UK. Anesthesia is the largest hospital specialty in the NHS. And in UK, to become a specialist, 7 years of postgraduate training. That includes exams, primary and final. And the syllabus, as you can see, basic sciences and clinical. But the bit really that people struggle with, or at least in my time in the 80s, is the basic sciences, specifically physics and equipment. At the time in the 80s, obviously there was no internet, so 100% rely on books. And the equipment books available at the time, only 2 books, one American and one British, and both of them share the same, being boring, very text-heavy, and most importantly, expensive for a trainee. I was working as a senior registrar in UCH, University College Hospital, and UCH is on Gower Street. Gower Street is one of the famous streets in London. For example, Charles Darwin lived there. The College University of London is there. London School of Hygiene, and as it happened, the first anaesthetic in England was administered on Gower Street. So I thought about it, and I thought about it, what does writing a book involve? I reached the conclusion. I was involved in a number of clinical research projects at the time, and I reached the conclusion that really writing a book is easier than publishing research. This is just a very quick illustration of how difficult it is to perform a research project. Really, writing a book is all you need is collect the information. No internet, but I was lucky. I was working in a university hospital, so a library full of books and journals, so that helped me a lot in collecting the information. It's easier nowadays, obviously. For those of you from the early 90s, probably remember that was the ultimate Cyan 3A PDA. That was the ultimate technology at the time to collect the information. So I basically collected as much whenever lunch break, on call, whenever I had the time, collect information as much as possible on this little gadget. And I reached, as I said, reached the conclusion that it's relatively easy to write a book. I don't have to reinvent the wheel again. The information is there. All you need is to rewrite it in a better English or a better format, easier, use illustration and make it much more reader-friendly. And literally, whatever the other competitors, I want to do exactly the opposite, the way how illustrate the book and the information. So use very simple English. A big trick is don't use long sentences, maximum 15 words. Longer than that, by the time you finish the sentence, you can't even remember what was the beginning of a sentence. 15 is the magic number. Colored images, boxes, illustrations, and also put some element of assessment to assess the reader, the student. Obviously, that book was aimed at undergraduate, postgraduate trainees, so they want to assess themselves. Have I missed anything in that particular chapter? Reached the conclusion that we need to make it easier for the reader. So a format, we agreed on a format, and we used that format for the whole of the book and proved to be very successful. So all bullet points, 1, 2, 3, 4, and people revising for exam or preparing for an exam, they found it much easier to understand. And at the end of each section, a little box with 3, 4 bullet points summarizes the things that they meant to learn from that section. And also more recently, the publishers suggested adding exam tips. So the questions they asked in the fellowship exams, one put a sort of a reminder, this is important to remember. Yeah, these are just examples. As you can see, the format is all bullet points, colorful illustrations, and a box summarizing the previous section. Exam tips, as I said, were the thumb up to remind the reader that this is an important topic you're going to get asked in the exam. And at the end of each chapter, suggested further readings, maybe 4 to 6, not too many references, and mainly really documents from Department of Health or from the MHRA, WHO, to people if they would like to get more information. And at the end of each chapter, depends on the chapter, anything between 10 and 15 MCQs or best single questions. Over the years, as I said, I'm talking about 33 years. Over the years, the competitors changed the way how they write their books. They started basically copying ours. So you need to decide really who you're targeting. Who is it? Is it students, undergraduates, or postgraduates? Are you aiming at doctors? Are you aiming at nurses? ODPs, what's called operating department practitioners. I think in this country they call them technology, anesthesia technology. So who is your readers? Also, what sort of countries or what parts of the world you are targeting. At the time we were told British books will not sell in America and American books will not sell in Britain. So different medicine, different practice, Don't try to just concentrate on UK, Europe, maybe Canada, Australia, India. Middle East, obviously. And really more recently, China. China is a huge, huge, huge market. And the publishers actually translating my book into a Chinese now. Then you decide how many authors should get involved in this project. Anything between 1 and 2 authors to more than 50 authors. Each way, advantages, disadvantages, depending on how you see it. Next, you find a publisher, and when you go and meet them, prepare a sample. Sample anything between 3 to 5 pages.
Dr. Baha, 3 minutes, please.
Thank you. 3 to 5 pages, because they want to evaluate. For them, it's an investment. They're going to put money into the process, so they want to see. Negotiate them with a contract. Don't accept the contract immediately. Negotiate with them. Try to get as much as possible royalties. And then marketing. Marketing, the publishers will market it. Meetings like this, I found it from experience, word of mouth is the best marketing. And then the cycle usually 5 years. So every 5 years, the publishers contact me. Can we write another edition? Can we write another edition? And they put it in digital and electronic, all sort of and now they are translating it into a Russian version and Chinese version. Now, what do you get out of it? Fun. I found it very exciting, interesting to get it. CV, maybe improve your CV. Monetary, it's not going to be selling like Harry Potter. So you're going to make some money. It pays, personally, it pays for a holiday for me and my wife once a year. So not a huge amount. So in summary, really try to think of a niche in the market where you can cover that niche. Collect the information, find a publisher, think of a unique presentation, and have fun. And I'm sure all of you, especially the previous speakers, I'm surprised that none of them is publishing it. You know, all these operations and things like that, publish it, write it up. It's fun. Medicine is fun, but it's boring, honestly. I personally, writing and publishing is much more exciting. Do I have more time? 1 minute? So we are in this library. So I wanted to test they claim that it is the biggest in Middle East. So I went to the lady during lunch break. And I said, I want to test you. How many books? She said, we have 1.1 million. So I said, right, this is my name. She took it. I said, research, find what I have written here. And she actually came back to me and she said, yes, I found you in journals and books, but they don't have them in paper format. They have them all digital. So I said to her, you passed my test. Thank you. Any questions? I'm happy for anyone interested after the meeting. I'm very happy to speak to.
It's my pleasure now to introduce Dr. Niga Rashid, a very special guest from Kurdistan, Iraq. She is a senior registrar in pediatric gastroenterology. She is an Arabic board-certified pediatrics and holds a certified professional diploma in total nutrition. Dr. Niga is currently working in Dr. Jamal Ahmed Rashid's teaching hospital. Her presentation will be From Childhood Adversity to Adult Obesity, the Role of Early Life Stress in Shaping Future Weight Outcomes. Please help me in welcoming Dr. Niga. Thank you.
It's such a great pleasure to be here. Thank you for the organizing and scientific committee. Thank you, Dr. Sarah, for the nice introduction. Okay, I'll talk about obesity, but this time from a different perspective. Like every one of us will think that obesity is happening because we are overeating and not exercising enough. That's if you look at obesity from a simple lens. But when you look at obesity from a deeper point and you dig deeper, you understand that there are so many, a cascade of correlated factors or that are associated with obesity, that are leading to obesity. One of the things that we don't talk so much about is childhood traumas, or what we call childhood adversities. That was my subject of the title of my research, From Childhood Adversities to Adult Obesity, the Role of Early Life Stress in Shaping Future Weight Outcome. The agenda of my presentation will be introduction, and then aim and objectives, methods, results, and then some discussion and implementations. That's what I mentioned about obesity. The idea of this research was gained from primary research done in that area, which was done by the CDC Case of Permanent organization in USA, California exactly, and this was the first and the largest study in the area of ACEs, or adverse childhood experience, included over 10,000 cases done in late 90s. If I use this once. Okay, what we mean by ACEs, adverse childhood experience, is around 10. So it is what defined by CDC Case of Permanent is 10 adverse childhood experience, although there are also so much more. But it's about act of delegation, which is child abuse, which could include physical, sexual, and emotional. There are 10 types of ACEs. We add 1 point for each type of ACEs, so the ACEs could vary between 0 and 10 points. In the actual study, I tried to find association between ACEs and these findings, which include 6 outcomes, but for the shortage of time, I'll try to concentrate on obesity only on this presentation. So I'll find the association between ACEs and obesity. There are so many pathways that are found that ACEs, or adverse childhood experiences, associated with leading to obesity, but the 2 major pathways are psychological pathway, which is ACEs will lead to depression and anxiety, unhealthy coping mechanism, including to overeating and sedentary lifestyle, and behavioral mechanism that children with ACEs may develop maladaptive behavior, such as poor nutrition and lack of physical activity, which could lead to obesity by itself. Why we are afraid from obesity? So the health consequences of obesity, I think most of you are aware of. They could have a mental health challenge, including anxiety, depression, and so many others, and they could have social consequences, including bullying and social exclusion, which also led to profound emotional and psychological scares, and physical health impact, including cardiovascular and diabetes, and so many consequences of obesity we know. The aim of the study was to find how common adverse childhood experiences are there in the Soleimani government, and to explore the potential link between health risk behavior leading to obesity and ACEs, which could lead to sparking a crucial discussion on the treatment and prevention of obesity. The study methodology was cohort study, retrospective cohort study. In the study, the participants, which were 948 cases, they felt their age were between 18 to 87 from Soleimani government. The participants filled out the original ACEs questionnaire, which was from the original questionnaire done by CDC and WHO. And as I mentioned, there are 10 types of ACEs. They also, the study, how to go back? Yes, the statistical analysis SPSS software version 26 was used, and the comparison between the correlation between variables and the results were considered significant if p-value was less than 0.05. And about obesity, how we reported obesity, self-reported height and weight of the cases were taken, and a BMI were calculated for them. And according to the WHO classification of BMI, cases of 30 and above were considered obese. About the results of our study, this is about the participant. 529 cases were male and 419 were female, aged between 80 and 87. And the education status, as you can see, 69% were higher education, high school or higher education. About the commonality of ACEs, we found that around 50% of the cases, 15% of the cases have 4 ACEs and more, and 26% no ACEs, and 59% had 1 to 3 adverse childhood experiences. About the percentage of ACEs type, among all the 10 types of adverse childhood experience, physical abuse was the most common ACEs reported, and then come the emotional abuse and neglect, and then the rest. 12.4% of our study population had a BMI of more than 30. We found that with increasing number of ACEs, there is increased risk of obesity. As you can see, we included cases from BMI of 30 and above, which was 12.4. So regarding commonality and type of ACEs, results were close to another study conducted between 2010 and 2030. In this area, which was a large study, 10,696 respondents were in the study, included in the study. More than 50% of the participants in the study also exposed to at least one type of adverse childhood experience. And a study done in Saudi Arabia, physical abuse and neglect were most common ACEs, same as our study. ACEs frequencies were more common in a study that the original study, which was done by CDC Kaiser, the first and the largest study in the area, which found that 36.1 of the participants experienced at least one type of ACEs, and 12.5 experienced 4 or more. In our study, it was 56% by 15%. This could be due to the cultural belief that in this area, hitting and swearing on a child is part of raising them. While other patterns of abuse and sexual abuse, parental separation, drug abuse was less common in our study because of the social stigma, and people may deny it even in their presence.
Dr. Niga, 3 minutes, please. Thank you.
I'm coming to the finals. As proven in the study done by this Williams and Sampson, international journal, which was published in International Journal of Obesity in 2002, and another study done in USA in 2016, the possibility of obesity and morbid obesity was mostly associated with physical abuse, but the general rate of obesity was less in this study compared to the other studies. This could be due to the lifestyle in the area and lower rate of obesity in general, but we don't have a critical data, like precise data about the rate of obesity in Suleimani city. So the key findings: common ACEs experience physical abuse, emotional abuse, psychological neglect, and domestic violence were most frequent ones. The prevalence of ACEs, 59.4 of the participants reported experiencing at least one type of ACEs. And association of obesity, the study found a strong graded relationship between ACEs and obesity. Over 15% of the participants reported 4 or more ACEs, linking to higher BMI, mean plus minus standard deviation 5.4, plus minus 2.68. P-value was 0.023. This table includes the interventional strategies, how to prevent and treat ACEs. It could be in the form of counseling and support, which address psychological issues from ACEs, in the form of therapy for the families and child psychology. Could be in the school-based programs in form of, which could be promoting healthy behavior and coping skills in the form of wellness program, and community engagement, which builds supportive network to reduce ACEs impact in a form of local outreach program and supportive groups, physical activity initiatives, which encourage exercise and healthy living in a form of community sport leagues and fitness classes.
Dr. Nigar, 1 minute, please.
Yes, this is the ACEs questionnaire for anyone interested, and this is my references. Thank you so much. Feel free to contact me, and this is my daughter in cultural Kurdish clothes. Thank you so much.
Now, I would like to introduce Dr. Riyad Rumi, specialist plastic surgeon in UNIO Plastic Surgery Clinic, Dubai, consultant aesthetic plastic surgeon in NKD Medical Limited, London, UK, fellow of International College of Surgeons, hold a diploma of American Board of Hair Restoration Surgery and an American Board of Cosmetic Surgery. His presentation will be scar migration technique to completely abolish forehead accidental scars. Thank you.
How do you change the slides? How do you change the slides?
The slides by this, I think this one, I don't know how. Maybe
Which one
this, maybe.
This one?
Yes, I think.
Good afternoon, ladies and gentlemen. My presentation today is about scar migration technique to completely abolish forehead scar. A 26-year-old lady consulted me with a view to remove accidental scars that she sustained 10 years earlier as an accident. Some attempts had been made by other surgeons to improve the scar to no avail or no success. I carried out a 4-stage forehead lifting to remove the scars completely. The final hairline scar was inconspicuous. This was due to the This was due to the trichophytic beveled incision technique, which preserved the hair follicles. This had led hair growing through the scar. Routine treatments for this kind of a scar is either surgical or non-surgical. Surgical, either direct revision or Z-plasty or flaps or tissue expansion. The non-surgical, either laser, dermabrasion, chemical peeling, skin lightening, skin color tattoo, PRP3 injection, or makeup. None of these methods succeed in this kind of scar. I have no financial or other interest to declare. This is the lady. As you can see, she sustained multiple scarring of her forehead. Some of them are Y-shaped, some are V-shaped, some hypertrophic. One of the scars extended up to 2/3 of the width of her forehead. She clearly made it to me that she really wants to completely remove the forehead scars, as it is causing her a lot of trauma. I prepared the patient. I prefer to shave the area so I can see the hairline clearly. Also to deal with she had other further scars within the hair scalp. The dotted line, the top one is the hairline margin, and the lower one is the planned excision for the first stage. And the red dotted area is the area that I intended to excise. There's a video of the procedure. There's some graphic contents in it. I inject 2 points only of concentrated anesthetic first, and then I use a gauge 27 spinal needle to infiltrate the area with tumescent fluid, which is a diluted, super diluted local anesthetic. I'm marking the second incision. We've already made the first hairline incision, and I always undermine a little bit of the hair scalp and plicate or fold the top flap to overlap the second one to measure how much I can cut out. As a really precision technique, a centimeter at a time. Now I'm making my lower incision to excise the scalp is a full thickness excision, skin, fat, and galea. You can see the field is almost bloodless. This is because the plane of excision is, the plane of dissection is subgaleal, which is very avascular, and also the help of the tumescent fluid. Very carefully, 1 centimeter at a time, very gently excising, because if you excise even 1 millimeter more, then you have difficulty in closing or too much tension. Now I'm just doing some further undermining. I undermine fairly far at the forehead flap up to the eyebrows, and but very little in the hairy scalp. So I use hooks to check. I'm just releasing a little bit more of the, so I'm excising the left side of the scalp, again gently and very, very slowly, and it's almost completely excised, and you can see totally bloodless. I always squeeze. I always check the tension because this is quite critical. The tension can jeopardize these flaps and can jeopardize the healing as well. So as I said, is really a millimeter of over-excision can lead to problems. I squeeze to check the tension. I'm doing further undermining the subgaleal, so between the galea and the periosteum, to get further glide of the galea and further movement. I'm doing the final check with using hooks for both flaps to check the tension, and I also ask the patient to raise her eyebrows. This is one of the advantages of doing the procedure under local anesthetic, because if it is important to ask her to raise her eyebrows to check the tension. I'm quite happy now. I'm doing closure. I close the 2 layers using absorbable sutures for the galea, and then interrupted nylon for the hairline. So this is first stage. I managed to remove about 1 centimeter of the full thickness scalp. So this has led to the migration of the linear scars upwards towards the hairline. And I leave a gap of 6 to 8 weeks before I do the second stage. So the patient underwent total of 4 stages, which had completely abolished or removed the scars in her forehead, leaving her with just a very thin, inconspicuous hairline scar. I have mentioned to the patient that she might need some hair transplant later on to cover the scar. Initially, she didn't want to, but then she immigrated to the United States, and 2 years later, she sent me a video. She said she's had just a few follicular units transplanted to the scar. But you can see this is a complete closure of the galea, and I did not need to. So this is a stage before stage 2. In other words, this is the result of stage 1. And you can see how far already the scars have migrated towards the hairline. And this is stage 3. In other words, that's just before, and this is the result of stage 2. So this is just before stage 3. And this is the final result. As you can see, 10 days after the last stage, just before removing her sutures, and you can see a complete migration of the scar, complete abolition of the scar. And this is the very final result, and you can see, you can hardly see the scar, and the hair already growing through the hairline scar. And very kindly, conclusion: the skin once is stretched, it undergoes mitotic activity. In other words, it manufactures a new tissue, new skin tissue. And the other alternative to this technique is by using tissue expanders, which would lead to unsightly swelling and the expenditure and multiple visits to fill in the expanders, etc. It's the kind of video she sent me, like 2 years post-operatively with complete abolition of the forehead scar. Thank you very much indeed.
Thank you, Dr. Riyad. Very interesting talk. It's my pleasure now to welcome Professor Zaki Al-Mallah to the stage. Professor Zaki is a clinical professor of urology. He is a fellow of the Royal College of Surgeons in urology. He is currently working at Cleveland Clinic in Abu Dhabi. His presentation will be From Diagnosis to Treatment, How AI is Reshaping Healthcare. Please join me in welcoming Dr. Zaki Al-Mallah to the stage. Thank you.
شكرا جزيلا. السلام عليكم وأهلا وسهلا. اسمي يحيى زكي الملاح. It's great to be here. And thank you very much for the organizers. It's really been a great day, especially seeing everybody at the ceremony with the presentations. We've heard a lot about AI and innovation. I'm just going to give you really a kind of an overview of what potentially can be the practice, which hopefully very soon within hospitals. So this is. As my disclosure. I think we'll start with this picture, which is it's an AI-generated picture, but it's you can see probably most of it is already in practice. So you can see we are using robotic surgery now in the middle, but here you can see assistants, which are robots. The surgeon here trying just to make sure that things are going in the right way. You've got a lot of information and live data with it from the patient, and the robot itself is almost automatically doing everything. So this is not far a picture because many of these technologies already in use. So just really to look, I think we're all obviously convinced that innovation is important in medicine, but just this is very a quick run of what could be done and how it's important. We all agree that using the right technology, with the right adoption of technology, we are going to improve patients' outcome, and we know this from our daily life. And also, it will improve our surgical techniques, our access to the patient. But also, we need to think about operational side. It will improve cost, access of healthcare. And we saw that during, for example, the COVID and Corona pandemic. We saw how access through digital technology, through virtual visits, how that all changed the way we practice. The story started with really, there are few specialities which you're all aware of that uses pixels and images, where they were really the forefront of adopting different AI technologies for dermatology, pathology, and ophthalmology because of retinal pictures. And this change things, and this has been going on for probably the last 10 years, and it's becoming a normal practice in many of these areas. In urology in particular, where the practice is the specific technology that we're looking at is about focal diagnosis in radiology, specifically for renal tumors, where you can scan and you get experience, and you use machine learning to try to diagnose things. For people who are involved in any images, it's very difficult sometimes to ascertain how wrong, how right. And it helps as a tool for clinical decision support. I mean, there are many radiology softwares now, especially things that require quick diagnosis, like in stroke, and myocardial infarctions, and in anything that require a quick diagnosis, you get a run and a suggestions by a software with some machine learning AI based software that will advise could be so and so, could be so and so. And obviously the ultimate decision is still in the hand of the doctor and the radiologist or dermatologist or ophthalmologist, depends on what specialty, but eventually this will be even more automated. In the area of prostate cancer is the same thing. So you have increasing images where try to detect prostate cancer by images. Obviously, for many of you, you know that PSA, for example, was the way of picking up cancer. Now we're using increasingly MRI, and then we're starting to try to use diagnosis for this, but also started to use the fusion of these images to use focal therapy rather than taking the whole prostate out, rather than using the old techniques of removing the whole organ. We're using more focal treatment because of the advances in how we identify, how we read, and how we focus images using old software with complex computer calculation. This is an interesting technology where it's used for benign prostate, for enlarged benign prostate. It's a technique called aquablation, and the principle of it is that you get a very accurate calculation of the prostate which is causing obstruction, and by doing so, you can really remove and resect part of the prostate which is, unfortunately, there was a video here, but it's not working, that you can resect using a special technology of a water jet, the obstructive part. And it's really automated. I mean, the input of a surgeon is currently, so I put the calculation in what was being done, and then the rest, the robot, which is based on a complex software background and AI technology and machine learning technology that cuts the obstructive part. But the AI is not, we only think about AI with complex technology and complex and surgery and operations. I think we need to think about simple things. I mean, one of the things I think that was an earlier discussion in the presentation in the morning, that you wait for 3 days for a urine culture, for example. So you don't know whether you start antibiotics, and we know from all studies that probably 40 to 60% of the antibiotics we start are unnecessary. So one of the areas that we can improve is how we predict, and it's a very simple way, how we can predict a positive culture. This is some work we did at Cleveland Clinic Abu Dhabi, and the way is that you use clinical data from the community, use clinical data for that particular person to try to predict precisely whether they have an infection or not based on their symptoms and the simple things like a simple test, and also try to predict the antibiotic resistance. And this could be used directly into your care, and that could be adopted. And many of you say, well, I can diagnose urinary tract infection, but that could be going into then pharmacies, could be going into a nurse could diagnose that, it could be in primary care, so it really changes how we do things. Another important thing is that we miss out is that many patients in hospitals can deteriorate very quickly, and we cannot precisely predict. Obviously, there are criteria for prediction, but that should be with all the information we have and all the data we have, that should be done automatically. This is a collaboration with the New York University, Abu Dhabi. Sorry, the pictures are they didn't project very well. We try to, with the simple data, we try to identify, stratify patients and get alerts of patients who are likely to deteriorate. Another work which is we need to kind of think about is the operational side from a hospital point of view. So we all worked with pharmacies and different pharmacies. We know the stock up and the inventory of pharmacy is based on calculation of what been using or whatever. But we've never occurred to us to use clinical data of what patients have used. This is a work we did with Mohammed bin Zayed University. We had a master's student, Ibrahim Hamid, who really worked on trying to predict the need for transplant medications in our hospital. And that's obviously not only will improve accuracy, obviously that model, clinical model, will need to improve, but also it looks at the amount of saving to the hospital and healthcare and hospital and profits that could be done. If you look at this, a simple medication for transplant, and you can see the cost implication of losing out. So there will be a cost implication or cost benefit or benefits financially for improving these precision way of stocking and inventory.
Professor Zeki, 3 minutes, please. Thank you.
Thank you. The other important thing is nursing and monitoring. This is kind of an increasingly adopted technology in how we monitor patients using a special camera system in rooms, and also how we can alert about any movement. This is a smart bed, so if the patient is moving, obviously we know falls in hospitals are very high, monitoring fluids and everything. And this is a technology we are just trying now, is to see whether we can identify risks within the room of the patient and alert the staff before there were any problems. Obviously, there are always challenges in adopting these technologies. There are the ethical concerns. Next week, for example, there's a big debate in the Arab Health about the ethics in AI in healthcare, and that's a big subject. I think we always need to be thinking about it. How we balance the technology with the human touch. Patients always want that kind of smile from the doctor, and the emotions and empathy, whether computer can provide that eventually or not. And also we need to think about collaboration among healthcare professionals, and more importantly, encourage research and further evaluation. Finally, we're all doctors here, we all have jobs. What is the implication for our jobs in the future? We were all people when started to have radiology images and software for diagnosis. People were saying, are we going to need radiologists in the future? A friend of mine, Dr. Omar, earlier on said, are we going to need surgeons in the future? So our jobs can be affected. But I think we need to think it in a different way. I think automation brought more job satisfaction, created more financial improvement. Our quality of life has changed. So I think we need to kind of embrace these technologies, because this will improve our quality of life and our jobs in a way or another. So in conclusion, ladies and gentlemen, AI is not a luxury. It is becoming a necessity, and it's important that we adapt and change and embrace such technologies. And thank you very much.
Thank you, Dr. Zeki, for a very interesting presentation. We would love to present our speakers with certificates of appreciation and show of our gratitude for your time and knowledge. Thank you very much.
Dr. Aisha.
المعمارية الراحلة زها حديد. خسارة ما بعدها خسارة. قد فقد العالم أسطورة، قد فقد العالم فارسة، قد فقد العالم أيقونة الحضارة. ماتت زها فبكاها الحبر والقلم، وبكاها الرسم والتصميم والناي والنغم. بكتها نوافذ الزجاج وبكتها الحجارة، بكتها القصور، بكتها الجسور، بكتها المساجد وبكتها المنارة، بكتها الطيور وبكتها النسور وبكتها أعمدة الحضارة. من يا ترى صمم الجنائن المعلقة؟ من بنى زقورة أور؟ من طرز باب عشتار بالمرايا؟ ومن عطر طاق كسرى بالبخور؟ فبعدك توقف العزف بالأقلام يا آخر قيثارة. والسلام عليكم.
شكراً.